Hello, I am Dr. Ann Curtis. The following informational video, provided by St. Jude Medical, will offer you information about the types of drugs used to treat cardiac arrhythmias. Arrhythmias are abnormal heart rhythms. They may cause the heart to beat faster or slower than normal, making the heart less effective in pumping blood through the body. Some common arrhythmias are bradycardia, supraventricular tachycardia, atrial fibrillation, ventricular fibrillation, and ventricular tachycardia. To treat your arrhythmia, your doctor may use one of or a combination of a variety of medications. These may be injected in an emergency situation, or you may need to take pills for long-term treatment. There are different categories of drugs used to treat arrhythmias. Let's review the major types of drugs that are often used to treat arrhythmias. The first category of drugs is called antiarrhythmics, and they're used in treating a variety of arrhythmias. These medications change how the heart's electrical system works. Antiarrhythmic medications can prevent abnormal heart rhythms from starting or continuing. Beta blockers are another category of medications that slow your heart rhythm and keep the heart from pumping so hard. They do this by blocking the action of nerve impulses to the heart. The next category of drugs used to treat arrhythmias is calcium channel blockers. These medications slow conduction of electrical impulses in the heart, which can either prevent arrhythmias from developing or slow them down if they do occur. Anticoagulants are another category of drugs commonly prescribed for arrhythmias. These drugs thin the blood and help prevent clots from forming in the blood vessels. Your doctor may call these blood thinners. Digoxin is a drug that may also be prescribed by your doctor. Digoxin helps the heart work more efficiently by strengthening the contractions and slowing some types of irregular heartbeats. Adenosine is a drug that is sometimes used in the emergency department. It is given by vein to stop certain types of heart arrhythmias. Remember to tell your doctor about all of the medications and vitamins you are currently taking. Don't stop taking any medication without talking to your doctor about it first. You should consult with your doctor before taking any over-the-counter drugs, such as cold medicine, as they may interfere with your heart medication. Tell your doctor of any side effects, like nausea or dizziness, you experience while taking the drugs. Thank you for watching. This video was created by St. Jude Medical to provide information about arrhythmias. This is not a substitute for medical advice. If you have questions, please talk to your doctor. Hello, I am Dr. Ann Curtis. The following informational video, provided by St. Jude Medical, will offer you answers to questions that are frequently asked about cardiac arrhythmias. Every heart has a normal rhythm. The normal heart rate is different for each person, but the usual range is between 60 to 100 beats per minute. Arrhythmia is the medical term for an abnormal or irregular heart rhythm that is defined by the speed and pattern of heartbeats. A very slow heart rate, called bradycardia, means the heart rate is less than 60 beats per minute. Tachycardia is a very fast heart rate, meaning the heart beats faster than 100 beats per minute. Arrhythmias are fairly common, especially as you get older. A common cause of arrhythmia is heart disease. According to the National Institutes of Health, heart disease affects more than 13 million Americans. An arrhythmia may cause the heart to pump less effectively. Some arrhythmias are irregular beats or temporary pauses that have little effect on the overall heart rate or rhythm. If the irregularity becomes more frequent, there may be a dramatic change in heart rate and rhythm, producing symptoms and illness. Conditions contributing to heart disease and arrhythmias are called risk factors. They can be family history, genetics, aging, high blood pressure, diabetes, stress, smoking, diet, and a lack of exercise. However, it is important to know that some cardiac arrhythmias occur in people with structurally normal hearts. While a healthy lifestyle is important for everyone, lifestyle changes themselves may not affect the frequency and severity of cardiac rhythm problems. You may feel tired, dizzy, short of breath, or have pounding and tightness in your chest. You may feel weak, sweaty, nauseated, or faint. You may even feel a rapid or irregular heartbeat when you take your pulse. You should contact your doctor right away if you are experiencing these symptoms. Arrhythmias are commonly diagnosed by a standard electrocardiogram or EKG done in your doctor's office. If the arrhythmia occurs infrequently, your doctor may prescribe a Holter monitor or an event recorder that will allow you to capture these irregular events when you feel symptoms outside the doctor's office. Some arrhythmias are seen during an exercise stress test. That is a treadmill or chemical test to evaluate your risk of heart disease. In some cases, your physician may refer you to an electrophysiologist, or EP, who is a cardiologist who specializes in heart rhythm disorders. The EP may recommend additional tests like a non-invasive tilt table exam or an electrophysiologic study that is performed in an EP laboratory in the hospital. Arrhythmias are generally categorized into two groups: SVT, supraventricular tachycardia, and VT, ventricular tachycardia. These categories refer to the chamber location where the arrhythmia originates. Supraventricular tachycardia refers to the two smaller of the four chambers of the heart. These are called the right and left atria, and they are located above the larger pumping chambers called the ventricles. So arrhythmias or tachycardias originating in the atria may also be called atrial arrhythmias. SVTs, or atrial arrhythmias, may include atrial tachycardia, atrial flutter, atrial fibrillation, AV nodal reentrant tachycardia, and AV reentrant tachycardia, sometimes called WPW, which was first described by the scientists Wolf, Parkinson, and White. WPW has a characteristic finding on the EKG that helps in the diagnosis. Most atrial arrhythmias are not life-threatening. Ventricular tachycardia comes from the two larger pumping chambers located beneath the atria. Arrhythmias here range from benign but nuisance arrhythmias that can occur in people with normal hearts to potentially life-threatening arrhythmias in patients with a history of heart attacks or heart failure. There are also genetic conditions that can lead to serious ventricular arrhythmias, such as ARVD, or arrhythmogenic right ventricular dysplasia, and long QT syndrome. Commonly, the first approach your doctor will take is to prescribe antiarrhythmic medication. These medications help to control the electrical activity in the heart muscle, reducing irritability and slowing electrical conduction through the chambers. Digoxin, beta blockers, and calcium channel blockers are the most commonly prescribed drugs. Other antiarrhythmic drugs commonly prescribed include flecainide, propafenone, sotalol, and amiodarone. Pacemakers are commonly implanted for bradycardia, or a slow heart rate. With sophisticated electronics, a small pocket-sized device is placed beneath the skin and delivers a battery-driven impulse through wires placed in the heart to supplement the heart's natural pacemaker. Ventricular arrhythmias that are life-threatening are sometimes treated by implanting a cardiac defibrillator, also called an ICD. Like having a paramedic in your pocket, they constantly monitor the heart for arrhythmias and provide pacing therapy as well as a powerful shock to restore a normal rhythm when necessary. Radiofrequency and cryogenic ablation may be performed in the hospital electrophysiology laboratory. These procedures involve threading special catheters from a site in the groin into large vessels that provide access to the heart. These catheters are used to deliver heat or cold directly to the diseased tissue and destroy the pathways causing the arrhythmia. In some cases, surgical procedures are performed. They may include open heart surgery, where incisions are made to interrupt electrical pathways in the heart causing arrhythmias. Other surgical techniques use a minimally invasive approach through a small opening in the chest wall. Instrumentation is introduced to the exterior surface of the heart, where radiofrequency and cryogenic ablation may be performed. Thank you for watching. This video was created by St. Jude Medical to provide information about arrhythmias. This is not a substitute for medical advice. If you have questions, please talk to your doctor.
Hi, I'm Dr. Frederick Ehlert. The following informational video, provided by St. Jude Medical, will offer you more information on atrial fibrillation. Atrial fibrillation, also known as AFib, is the most common heart rhythm abnormality, affecting about 2.2 million Americans. Aggressive treatment of AFib is often recommended by doctors in order to prevent strokes and sudden cardiac arrest. Atrial fibrillation is a very fast, uncontrolled heart rhythm that occurs when the upper chambers of the heart, the atria, try to beat so fast that they actually quiver. A normal resting heart usually beats between 60 and 100 times per minute. During AFib, the upper chambers beat between 350 and 600 times per minute. Due to the erratic rhythm in the upper chambers, the rhythm of the lower chambers of the heart will also become irregular. Because the rhythm in the upper chambers is not normal, the pumping function of those chambers is compromised and blood is not completely emptied from those chambers. This causes the blood to pool and sometimes clot. If a clot in the atria leaves the heart and becomes lodged in an artery of the brain, it can result in a stroke. Symptoms of AFib include irregular heartbeat, shortness of breath, chest discomfort, weakness, dizziness, and decreased ability to exercise. Heart attack survivors and those with other heart disease are less able to tolerate AFib. There are a number of treatment options for AFib. The first line of therapy usually involves medication. However, there are other treatments which may be appropriate for qualifying individuals. These include electrical cardioversion, implantable devices, and ablation. There are two types of electrical cardioversion, external and internal. During external cardioversion, two paddles are placed on the patient's chest that deliver a high-energy shock to the heart, jolting the heart out of AFib and back into a normal rhythm. In a similar fashion, internal cardioversion uses a small wire called a catheter inserted through a vein to deliver a shock to the heart, stopping AFib. An implantable device, such as a pacemaker or an ICD, can be used to pace the heart in certain patterns and stabilize the heart's rhythm to prevent the occurrence of AFib. An ICD can also be used to deliver electrical shocks when AFib occurs. This function can be activated when the patient experiences symptoms or programmed to automatically deliver therapy. Ablation for AFib is based on the idea that ablating or cauterizing areas of heart tissue will help the heart remain in normal rhythm. This procedure is typically done with catheters inserted through a vein and positioned in the heart. It can also be done surgically. During an ablation, an electrophysiologist or a cardiac surgeon pinpoints areas in the heart critical for AFib to occur and ablates or destroys these small areas. As a result, this tissue is no longer capable of conducting or sustaining the AFib. Ablation for AFib is a relatively new procedure, and significant advances in its effectiveness continue to be made. Thank you for watching. This video was created by St. Jude Medical to provide information about atrial fibrillation. This is not a substitute for medical advice. If you have questions about a heart condition, please talk to your physician.
Hello, I'm Dr. Romualdo Segurola. The following informational video provided by St. Jude Medical will offer an overview of coronary artery disease. Coronary artery disease is the most common heart disease, and it is the #1 cause of death for both men and women in the United States. Healthy arteries are flexible, strong, and elastic. Their inner layer is smooth, allowing blood to flow freely. As you age, your arteries become thicker and harder, and plaque deposits may build up inside of them. As plaque builds, it narrows the coronary arteries, and it makes it harder for the blood to flow through to the coronary arteries, causing chest pain, shortness of breath, and fatigue. This hardening of arteries is called atherosclerosis or arteriosclerosis, and is the main cause of coronary artery disease. Left untreated, progressive coronary artery disease can lead to myocardial infarctions, which is also called a heart attack, or to sudden cardiac arrest. Your cardiologist will do a thorough medical history and physical exam and probably order diagnostic tests if coronary artery disease is suspected. These tests could include an electrocardiogram, blood test, or a stress test. The most definitive test for examining the coronary arteries themselves is an angiograph. Angiography is typically on an outpatient basis and is commonly called cardiac catheterization. During the cardiac catheterization procedure, a small catheter will be placed in an artery of your arm or leg. Using images from an X-ray machine, the doctor then guides a catheter to the opening of each of the coronary arteries. A small amount of dye or contrast is injected into the arteries so they can show up on an angiographic X-ray. A series of pictures is taken from different angles and views to locate all areas of blockage in the coronary arteries, which will enable the physician to make a diagnosis. Treatment for coronary artery disease is focused on providing sufficient blood flow to the heart and often is treated through a combination of methods, including medication, angioplasty with a stent, and coronary artery bypass surgery. Medication usually is the first line of defense and may be prescribed to control the symptoms of coronary artery disease and to slow its progression. Angioplasty is a surgical procedure performed to restore blood flow to the blocked arteries in the heart. During angioplasty, the doctor inserts a guided catheter into an artery in the arm or leg. Another catheter with a balloon tip is then inserted into the initial catheter and guided up to the blockage in the heart. The balloon is then inflated and deflated several times to compress the blockage and widen the narrowed artery. Your doctor may choose to keep the artery widened by placing a small wire mesh called a stent into the artery. After an angioplasty, you will be moved to a recovery area where you will have to lie flat on the bed for 4 to 8 hours to give the puncture vessels an opportunity to close completely. If the vascular closure device has been used, you may begin moving much earlier and you will be able to be discharged sooner. Another therapy for treating coronary blockage is coronary artery bypass grafting, also called CABG. CABG surgically places a vein or artery from another part of the body to bypass the blocked areas in the coronary artery. This allowed improved blood flow and oxygen to the muscle of the heart. After the procedure, you will probably spend 5 to 7 days in the hospital. Your doctor may choose to put you in a normal hospital room or a transitional care unit where you may begin cardiac rehabilitation. As your incision heals, watch for redness, swelling, or increased tenderness. Generally, your incision will feel better in a few days. Recovery from any surgery varies for each patient. Most patients start feeling better and gradually increase their activity in about 4 to 6 weeks. It is important in the postoperative phase to follow your doctor's instructions closely and to report any problems you might have immediately. As with all heart disease, lifestyle changes may be beneficial. Eating a healthy diet, staying active, maintaining a healthy weight, reducing stress, and not smoking all contribute to a healthy heart. Thank you for watching. This video was created by St. Jude Medical to provide information about coronary artery disease. This video is not a substitute for medical advice. If you have any questions, please talk to your doctor.
Hello, I'm Dr. Marie-Noelle Langen. The following informational video provided by St. Jude Medical will offer you a definition for the ejection fraction of your heart and explain why this number is important. The ejection fraction, or EF, refers to the amount of blood pumped out of the heart with each beat. Ejection fraction is an important measure of how well your heart muscle is functioning. No matter how well a heart is pumping, it never pumps all of the blood out of its chambers. A normal heart pumps 55 to 75% of its blood out with every beat. That is described as an EF of 55 to 75%. When a heart pumps only 40 to 54% of the blood per beat, it may indicate damaged heart muscle due to a previous heart attack, heart muscle disease, or heart valve problems. If the EF is less than 40%, it may indicate some degree of heart failure. Your cardiologist can measure your ejection fraction with several types of tests. The results of the tests can help determine the amount of heart failure and the best course of treatment. The first of these tests is often an echocardiogram. This painless test uses sound waves to show images of your heart and how well it is working. An echocardiogram is performed by a technician either in your doctor's office, a hospital, or a testing center. If an echocardiogram doesn't provide enough information, your doctor may also order a cardiac catheterization, an MRI of your heart, a nuclear medicine scan, or a CT scan of your heart. These detailed tests are performed by trained technicians, usually in a hospital or a lab. These tests, combined with the echocardiogram, will provide more specific results on your heart's condition and how well it is functioning. After the testing is complete, your cardiologist and/or electrophysiologist will interpret the results and recommend treatment. If a low ejection fraction is left untreated, it can lead to sudden cardiac arrest, which has a 95% mortality rate. A low ejection fraction may be caused by an underlying condition, such as high blood pressure, coronary artery disease, or heart failure. If this is the case, treatment should be focused on reducing symptoms and preventing the underlying disease from progressing. The treatment plan often includes lifestyle changes and medications. Your doctor may also recommend an implantable cardioverter defibrillator, often called an ICD. An ICD is a device designed to slow down certain fast heart rates. It is implanted under the skin and attached to the heart with small wires called leads. The ICD monitors the heart rhythm. If the rhythm becomes dangerously irregular, the ICD treats the heart by pacing or delivering a shock to return it to normal rhythm. More than 35,000 ICDs are implanted each year. They have proven to be 98% effective in restarting hearts after sudden cardiac arrest. Thank you for watching. This video was created by St. Jude Medical to provide information about ejection fraction and how it affects heart health. This video is not a substitute for medical advice. If you have questions, please talk to your doctor.
Hi, I'm Dr. Aisha Arshad. The following informational video provided by St. Jude Medical will lead you through a description of tachycardia, therapy including techniques, and post-surgery information. Ventricular tachycardia occurs in approximately 2 out of 10,000 people. Tachycardia comes from the Latin words meaning swift or rapid heartbeat. It's an irregular rhythmic beating of the heart during which the heart muscle contracts in a rapid manner, which disrupts the normal pumping and flow of blood into the body. Tachycardia is a cardiac arrhythmia characterized by a rate of more than 100 beats per minute. Tachycardia may be normal, for example, when induced by exercise. However, it can also prevent the heart from pumping an adequate amount of blood to the body. There are 2 forms of tachycardia: supraventricular tachycardia, SVT, and ventricular tachycardia, VT. In SVT, the arrhythmia originates above the ventricles and can be corrected using various treatment options. In VT, the arrhythmia originates within the ventricles and may be life-threatening and needs evaluation by a physician. Clinicians further classify tachycardia as non-sustained, lasting 30 seconds or less, or sustained, lasting 30 seconds or more. Tachycardia can develop as an early or late complication of a heart attack, as a result of heart disease, following heart surgery, or as a side effect of heart medication. Symptoms include lightheadedness, shortness of breath, and chest pain. Upon diagnosis of tachycardia, a physician may choose to treat the patient using medication or ablation, which involves cauterizing an area of the heart to eliminate the responsible tissue. However, if these techniques are ineffective, another option for treating ventricular tachycardia for those who are at risk of cardiac arrest may be an implantable cardioverter defibrillator or an ICD. The ICD system looks and works much like a pacemaker. It detects sustained tachycardia and delivers a small electrical impulse to the heart to restore the heart's normal rhythm. The device is implanted under the skin and attached to 1 or more leads or pacing wires, which are placed in or on the heart muscle. During surgery to implant an ICD, a lead is inserted through a vein in the body. The tip of the lead, called an electrode, is then placed in 1 or more of the heart's chambers. The other end of the lead is attached to the ICD, which is usually placed in the chest, just under the skin. After having surgery to implant a medical device, you will experience some initial discomfort. However, over the next few weeks, this will resolve completely. Perhaps the most important factor in the recovery process is getting regular checkups. During each visit, your doctor will use a computer to analyze information from your device, interpret that information, and sometimes change the settings to adapt to your condition. Your doctor will also check the battery of your ICD, which lasts on average between 4 to 6 years. When the battery begins to run low, your doctor will schedule a simple surgery to replace it. Most patients leave the hospital the same day they check in for the procedure. Thank you for watching. This video was created by St. Jude Medical to provide information about cardiac rhythm disorders and implantable device therapy. This is not a substitute for medical advice. If you have questions about a heart condition, please talk to your physician.
Hi, I'm Dr. Charles Machel. and along with St. Jude Medical, we have created the following video series to provide you with more information on the heart. I will discuss how the heart works, the coronary circulation, and the heart's anatomy. About the size of your fist, the human heart is the most important muscle in the body. It can beat more than 100,000 times a day, pumping about 2,000 gallons of blood through a 60,000-mile network of vessels in the body. The human heart is made up of 4 major chambers: the right atrium, right ventricle, left atrium, and left ventricle. The right side of the heart receives blood that is low in oxygen from veins all over the body. It then pumps the blood through the pulmonary arteries into the lungs where it will become reoxygenated. The left side of the heart receives this oxygen-rich blood from the lungs. Then it pumps the blood through the aorta back out to the rest of the body through a complex network of arteries, arterioles, and capillaries. While blood is circulating through the body, it delivers oxygen and nutrients to tissue through the capillaries, and at the same time picks up carbon dioxide and other waste material. The veins return the deoxygenated blood to the right atrium, and the cycle begins again. The heart has 4 valves. Each valve is like a one-way door that keeps the blood in the heart flowing in the same direction. The valves are made up of 2 or 3 small but strong flaps of tissue called leaflets. Leaflets open to allow blood to flow through the valve and close to prevent blood from flowing backward. The opening and closing of the valves is controlled by blood pressure changes within each heart chamber. The tricuspid valve is positioned in the heart's right side between the right atrium and right ventricle. The pulmonic valve separates the right ventricle from the pulmonary artery. The mitral valve is positioned in the heart's left side between the left atrium and the left ventricle. And the aortic valve separates the left ventricle from the aorta. As blood circulates through the heart, some of the blood flows into a set of much smaller blood vessels that provide blood directly to the heart. These arteries, called coronary arteries, surround or crown the heart. This separate circulatory system, called coronary circulation, keeps the heart nourished and oxygenated. The 2 main branches of the aorta that nourish the heart are the right and left main coronary arteries. Coronary artery disease, which occurs when there is a buildup of cholesterol plaque, affects the arteries of this circulatory system and causes a decrease in blood flow to the heart muscle, resulting in possible damage to the heart or a heart attack. The beating of the heart, which is its rhythm, is regulated by electrical impulses generated by your heart muscle. These impulses begin in the sinoatrial node and cause your heart to contract. Sometimes the sinoatrial node is also referred to as your heart's natural pacemaker, since it keeps the heart rate constant and consistent. The impulses then travel to the atrioventricular node, where the signal is checked and then sent through the ventricles, which causes them to contract. Your heart rate can change based upon external conditions such as diet, exercise, stress, or even hormonal factors. Thank you for viewing St. Jude Medical's video series on the human heart. This video was created to provide information about the heart. This is not a substitute for medical advice. If you have questions about the heart, please talk to your physician.
Hi, I'm Dr. Tom Mattione. The following informational video, provided by St. Jude Medical, will offer you more information on heart attacks. It will lead you through a description of the condition, its symptoms, and treatment options. The World Health Organization reports that heart attack is the #1 cause of death for men and women all over the world. However, it is not always fatal and is treatable. A heart attack, also called a myocardial infarction, or MI, refers to a sudden event in which a portion of the heart muscle stops working because it no longer receives blood, usually due to blockage in the coronary artery. The blockage occurs when plaque, which is made up of cholesterol, calcium, and other plaques, builds up and then ruptures inside the artery. As a result, a blood clot can form and eventually can block the coronary artery. This stops blood flow and prevents blood and oxygen from reaching the heart tissue. When tissue is starved of oxygen, it is referred to as being ischemic. Without blood and oxygen, the tissue dies and the damaged heart muscle is unable to function. The degree to which a patient is affected depends upon the location and size of muscle damage. Heart attacks are the result of multiple factors. Some of these factors include high cholesterol, smoking, stress, diabetes, age, gender, race, and family history. The symptoms of a heart attack can be apparent, such as intense, prolonged chest pain, also called angina. Other visible symptoms include cold sweats, discomfort in the arms, back, neck, jaw, or stomach, vomiting, and lightheadedness. For some people, there may not be any signs at all. However, if symptoms do occur, proceed to the emergency department of your local hospital as quickly as possible. A combination of blood and diagnostic tests, such as an electrocardiogram and chest X-ray, are usually used to diagnose a heart attack. Talk to your doctor about measures you can take to avoid a heart attack. In some cases, medication such as nitroglycerin is used to treat a heart attack. However, if ineffective, doctors may employ one of two surgical procedures, angioplasty or coronary artery bypass graft, also called CABG. Angioplasty uses a balloon to compress or break up the blockage and widen the narrowed artery, thus restoring blood flow to the heart. Cardiologists may also choose to widen the artery by placing a small tubular structure, called a stent, inside the vessel to keep it from clogging. A stent acts like scaffolding, supporting the walls of the vessel. CABG uses a vein or artery, usually taken as a graft from a vein in the leg, to bypass a blockage in the coronary artery and carry oxygenated blood around the blocked artery to the tissue, reestablishing blood flow. The grafting procedure usually involves sewing the graft vein to the coronary arteries past the point of the blockage. The other end of this vein is then attached to the aorta. After suffering a heart attack, a physician will work with the patient to analyze their current medical condition and lifestyle and prescribe a course of treatment to prevent further damage to the heart. This is a vital step in the treatment process because, as a result of their heart attack, many survivors will begin to experience abnormal heart rhythms called arrhythmia. If untreated, arrhythmia can lead to other medical problems, including sudden cardiac arrest and death. It is important to note, however, that a heart attack is not always a cause of arrhythmia and that sudden cardiac death is not always preceded by a heart attack. Thank you for watching. This video was created by St. Jude Medical to provide information about myocardial infarction and treatment. This is not a substitute for medical advice. If you have questions about heart conditions, please talk to your physician. Hi, I'm Dr. Tom Mattione. The following informational video, provided by St. Jude Medical, will lead you through a description of heart block, treatment, and post-surgery information. Heart block is a type of bradycardia that occurs when the heart beats slower than 60 beats per minute. It is sometimes called AV block after the atrioventricular node, which joins the upper and lower chambers of the heart. It is in the AV node that heart block originates. Heart block occurs when the beat that originates in the upper chambers of the heart is unable to pass to the lower chambers of the heart. There are three different classifications. In first-degree heart block, the beats pass from the upper to the lower chambers, but at a slower rate. In second-degree heart block, some beats pass from the heart's upper to the lower chambers, but some are dropped. In third-degree, or complete heart block, the beats cannot pass from the upper to the lower chambers, so the lower chambers create their own beats. This means they do beat and pump blood, but slower and less efficiently than if prompted by the upper chambers. As a result, the heart might not pump enough blood to meet the body's needs, causing lightheadedness, shortness of breath, palpitation, and chest pain. Heart block is usually treated with a permanent pacemaker. A pacemaker is a small electronic device that is designed to regulate the beating of the heart and is implanted under the skin just below the collarbone. During implantation, a lead or pacing wire is inserted through a vein in the body. The tip of the lead, called an electrode, is then placed in one of the heart's chambers. The other end of the lead is attached to the pacemaker. Inside the pacemaker is a battery, which acts as a power source for the device, and a tiny computer that listens to the heart's native electrical rhythm. If the device doesn't sense any electrical activity within a certain time, it stimulates the heart to beat. After having surgery to implant a medical device, you may experience some initial discomfort. However, over the next few weeks, you will notice that the symptoms of heart block are lessening and quality of life is improving. Perhaps the most important factor in the recovery process is getting regular checkups. During each visit, your doctor will use a computer to collect information from your device, interpret that information, and sometimes change the settings to adapt to your condition. Your doctor will also check the battery of your pacemaker, which lasts on average between 4 and 6 years. When the battery begins to run low, your doctor will schedule a simple surgery to replace the pacemaker. Most patients leave the hospital the same day they check in for the procedure. Thank you for watching. This video was created by St. Jude Medical to provide information about heart block. This is not a substitute for medical advice. If you have questions, please talk to your physician.
Hi, I'm Dr. Frederick Ehlert. The following informational video, provided by St. Jude Medical, will offer you more information about heart failure. It will cover symptoms, diagnosis, and treatment options. Heart failure is a large problem in the United States, affecting between 4 and 5 million people, half of whom are over the age of 65. However, there are multiple treatment options available to help reverse the effects of this deteriorating disease. Heart failure occurs when the heart is unable to contract or relax properly, leading to an increasingly ineffective heart as its ability to pump blood is lessened. As heart failure progresses, the body attempts to compensate for it by increasing the size of the heart so that it can pump more blood to the body. This is also called remodeling. While the remodeled, enlarged heart initially pumps more blood, it eventually requires more oxygen than is available, resulting in further damage and decreased pumping efficiency. In addition, heart failure can keep the kidneys from adequately ridding the body of fluids. Heart failure has many causes. Coronary artery disease affects about 50% of patients who suffer from heart failure. Other causes include high blood pressure, arrhythmias or abnormal heart rhythms, heart valve disease, congenital heart disease, and diabetes. Frequently, the cause is unknown. The symptoms of heart failure include general fatigue, shortness of breath, and severe swelling, especially in the legs and ankles. Your doctor may use various techniques to diagnose heart failure, including taking your medical history, conducting physical exams, and running diagnostic tests, such as an electrocardiogram, chest X-ray, or echocardiogram. Heart failure typically is treated with changes in lifestyle and a combination of medications, which tend to be more effective when the disease is in its earlier stages. However, advanced heart failure may require more invasive techniques, such as external counterpulsation, cardiac resynchronization therapy, a left ventricular assist device, or even heart transplant. During external counterpulsation, pressure cuffs on the legs are inflated in sequence. As a result, the blood vessels in the legs are gently compressed and the blood is forced back to the heart. This routine is performed over a period of several weeks, with each session lasting from 1 to 2 hours. Cardiac resynchronization therapy, or CRT, delivers electrical impulses to the heart's 2 lower chambers and 1 of the heart's upper chambers. This is called biventricular pacing, and it causes both ventricles to beat at the same time. CRT is administered using a pacemaker called a CRTP, or an implantable cardioverter defibrillator, also called an ICD. The device is implanted just like a standard pacemaker or ICD, except that a third pacing lead is added to help stimulate the heart's left lower chamber, or left ventricle. A left ventricular assist device, or LVAD, is a mechanical pump that helps the heart to beat normally when it cannot do so on its own. Most patients using an LVAD are awaiting heart transplant. Heart transplant is often a last resort treatment and involves replacing the failing heart with a live, healthy heart. Transplants are performed in only about 1% of patients with advanced heart failure due to the scarcity of donor organs. This video was created by St. Jude Medical to provide information about heart failure. This is not a substitute for medical advice. If you have questions about a heart condition, please talk to your physician.
Hello, I'm Dr. Clifton Lewis, and the following informational video provided by St. Jude Medical will offer you an overview of heart valve diseases. The human heart is essentially a four-chambered, self-priming pump, and it has a series of four check valves, pieces of tissue that act like a one-way door that keep the blood in the heart flowing in one direction, forward. Diseases of the valves have two basic causes: congenital valve disease that you're born with, and acquired valve disease that you develop with age. In most cases, there's nothing you can do to prevent heart valve disease. The one exception is rheumatic fever, which occurs as a sequela of strep throat, so you must be sure to treat strep throat with antibiotics. A physical exam is often the first indication of valve disease. If your doctor suspects a problem with your heart valve, you may be asked to undergo an echocardiogram or echo, which is a non-invasive type of ultrasound. Other diagnostic tests may include a chest x-ray or cardiac catheterization. A cardiac catheterization is an invasive procedure during which small catheters or small thin plastic tubes are placed in the artery of the leg or arm and directed using an x-ray machine into the heart. Small amounts of a dye-like substance called contrast media are injected and x-ray pictures are taken. These images enable your doctor to see if the heart valves are damaged and not working properly. After the procedure, you will be moved to a recovery area or your room. You will have to lie flat in bed for 4 to 8 hours unless the vascular closure device has been used, in which case you may begin to move earlier. Talk to your doctor about these options prior to your test. If you are diagnosed with a heart valve disease, one of two things is happening. Either the valve doesn't close tightly enough, called incompetence, to keep the blood from backing up into the chamber from which it flowed, or it doesn't open widely enough, a condition called stenosis, to allow adequate amounts of blood to flow out of the chamber. Aortic stenosis occurs in approximately 5 out of every 10,000 people and is more common among men and is increasingly common as you age. The symptoms of aortic stenosis include chest pain, shortness of breath, and lightheadedness. The most common type of valve disease is mitral valve prolapse, or MVP. MVP does not always require treatment, but it can lead to mitral incompetence. Mitral valve prolapse, which is also known as floppy valve syndrome, is a bulging of one or both valve leaflets. The leaflets on the mitral valve are floppy and bulge back into the left atrium, allowing blood to flow backward. If a significant amount of blood flows back into the heart's chamber, irregular heartbeats called arrhythmias, weakening of the heart, and congestive heart failure will commonly develop. Most people with MVP are born with it. It tends to run in families and is more common in people with connective tissue disorders. Many people with MVP have no symptoms. It is often discovered during a routine physical examination when the doctor checks your heart and hears a whooshing sound or murmur. If someone with MVP does experience symptoms, they often report heart palpitations, shortness of breath, or chest discomfort. A few simple concepts govern the treatment of valve disease, and if you understand these concepts, then treatment options become easier to comprehend. First, valve disease is a structural or mechanical abnormality that requires a physical or structural treatment. Essentially, this is a surgical disease that has no effective medical treatment. There's currently only one way to fix a broken valve, and that is to operate on the heart and repair or replace the valve. The second important concept to understand is, when is it appropriate to operate on a diseased valve? Most people can have valve disease for decades and not require treatment. In essence, they can be safely observed by their physicians, and it's only when a valve represents a risk to your life or negatively affects the quality of your life that they require treatment, i.e. an operation. Your cardiologist is best suited to help you know when to treat your valve disease. Thank you for watching. This video was created by St. Jude Medical to provide information about heart valve disease. This video is not a substitute for medical advice. If you have questions, please talk to your doctor. Hello, I'm Dr. Clifton Lewis. The following informational video provided by St. Jude Medical will offer you an overview of heart valve repair and replacement. Each year, there are approximately 225,000 valve operations performed worldwide. Your doctor will help you decide when it is appropriate to treat your valve disease and determine whether or not your valve needs to be completely replaced or merely repaired. Throughout the world, 95% of all valve replacements are performed for mitral or aortic valve disease. The mitral valve is positioned on the heart's left side between the left upper chamber, the left atrium, and the left lower chamber, the left ventricle. The aortic valve separates the left ventricle from the aorta. In most cases, aortic valves require replacement. Conversely, most mitral valves can usually be repaired. Today, there are two types of artificial or prosthetic valves used for replacement: mechanical or tissue. A mechanical valve is carefully designed to mimic the native heart valve. It has a ring, like your own natural heart valve, to support the leaflets. A mechanical valve opens and closes with each heartbeat, permitting proper blood flow through the heart. To prevent blood clots from developing on the valve, which can cause complications, a mechanical valve replacement requires you to take anticoagulation medicine or blood thinners daily for as long as you have the valve. A tissue valve is a native valve taken from an animal. Once it is removed, it is chemically treated and prepared for human use. Some tissue valves have a frame or a stent that supports the valve. Eliminating the stent makes it possible for the surgeon to implant a larger valve. Larger valves generally provide more surface area for greater blood flow to accommodate the body's needs. A homograft or allograft is a human valve obtained from a human donor. Donor valves provide excellent hemodynamic performance, allowing for natural function of the surrounding structures. Because the availability of these valves depends on organ donors, supply is limited. Some heart valve problems do not require complete replacement. Rather, the problem can be fixed by repairing the valve. When possible, repair is favored over replacement. There are various techniques that can be used, and the method selected depends on your specific valve abnormality. Mitral valvuloplasty is a technique aimed at ensuring the leaflets of the valve close properly, preventing blood from leaking back into the left atrium. A commissurotomy is a type of valvuloplasty that is used when the leaflets of the valve become stiff and actually fuse together at the base, which is the ring portion or annulus of the valve. Annuloplasty is a technique aimed at repairing the fibrous tissue at the base of the heart valve or the annulus. Sometimes the annulus becomes enlarged or dilated, which enables blood to back up into the left atrium. To repair this, sutures are placed around the ring to make the opening smaller, creating a purse string effect around the base of the valve. Usually, an annuloplasty requires the implantation of a stiffening ring to support the annulus. Recent technology has allowed surgeons to perform valve replacement or repair with less invasive techniques, instead of using a conventional open chest procedure or sternal splitting. This is not always an option and may depend on whether the hospital has the technology available. In some cases, minimally invasive techniques are not possible because patients require multiple cardiac procedures. Minimally invasive valve operations offer a number of advantages. Less surgical trauma translates into lower transfusion rates, lower rates of wound infections, a faster recovery, a superior cosmetic result, and in the case of mitral valve leakage, significantly improved repair rates. Conventional heart valve surgery typically requires a hospital stay of a few days to a week, followed by 6 to 8 weeks of recovery at home. Minimally invasive approaches cut recovery time by at least a half. Of course, each patient recovers at a different rate. Your physician will work with you to determine the right amount of recovery time needed. Thank you for watching. This video was created by St. Jude Medical to provide information about heart valve repair and replacement. This video is not a substitute for medical advice. If you have questions, please talk to your doctor.
Hi, I'm Dr. Charles Machel. Welcome to InsideCardiacArrest.com. Here you will find what you need to know about sudden cardiac arrest, risk factors, treatments and therapies for sudden cardiac arrest, and helpful information about your heart. The American Heart Association reports that every day in the United States, almost 900 people experience sudden cardiac arrest. That's more than 325,000 people a year. Sudden cardiac arrest, or SCA, occurs when the heart abruptly stops beating, halting the circulation. Paradoxically, the rhythm of the heart is actually a rapid, irregular rhythm called ventricular fibrillation, or VF. When the ventricles fibrillate, they don't contract normally, making it impossible to pump blood or oxygen to the body. People who have survived a previous heart attack or who have been diagnosed with some forms of heart disease are at risk for sudden cardiac arrest. Cardiologists measure heart function by a number called ejection fraction. The ejection fraction, or EF, is the percentage of blood that is pumped out of your heart during each beat. Medical research has shown that people with a low ejection fraction are at risk for developing abnormal heart rhythms and sudden cardiac arrest. An echocardiogram is a commonly used test to determine EF. Sudden cardiac arrest often occurs without any warning at all. However, some symptoms include sudden collapse, loss of consciousness, abnormal breathing, and inability to find a pulse or loss of blood pressure. Without immediate treatment of sudden cardiac arrest, there is little chance for survival. Options for immediate treatment include cardiopulmonary resuscitation, or CPR, to help keep the heart and blood pumping, or the use of an automated external defibrillator to shock the heart and restore it to a normal rhythm. People who recover from sudden cardiac arrest or who have the potential for sudden cardiac arrest may receive an implantable cardioverter defibrillator, also called an ICD. An ICD is a small programmable internal defibrillator that can be implanted in patients that are at high risk for sudden cardiac arrest. To know if, when, and what type of therapy might be needed, the ICD monitors or senses the heart 24 hours a day. While pacemakers can speed up a slow heart rate, ICDs are designed to slow down a fast heart rate. In addition, many ICDs also contain a built-in full-featured pacemaker. The device is implanted under the skin and attached to one or more leads, or pacing wires, which are placed in or on the heart muscle. During the implant, a thin insulated wire called the lead is inserted through a vein in the body. The tip of the lead, which is called an electrode, is then placed in one of the heart's chambers. The other end of the lead is attached to the ICD, which is usually placed just under the skin in the chest. When an ICD detects an irregular heart rhythm, it is programmed to send treatment, an electrical shock, to your heart. ICDs also constantly monitor your heart's rhythm. A special tabletop computer called a programmer enables a physician to talk to the ICD after it has been implanted. The physician can evaluate the ICD's performance and change settings without the need for further surgery. A telemetry wand is placed on your chest over the implanted device, enabling the ICD to communicate with the programmer and vice versa. More than 35,000 ICDs are implanted every year, and they've been proven to be over 98% successful in restarting hearts that have gone into sudden cardiac arrest. After the procedure, you may feel drowsy or experience some tenderness and soreness at the implant site, but by the next day, you'll probably be able to perform most necessary daily activities. It is important, though, to remember that everyone recovers at a different pace. When you return home, you should relax and take it somewhat easy. It is common to tire easily after surgery. Also, avoid sudden jerky movements with your arms or stretching or reaching over your head. Physical activity may be resumed once the incision is healed. It may be beneficial for patients to begin taking short walks or to engage in another form of mild activity to get into shape. Your physician will tell you which activities can be resumed and when. It's important for you to follow your physician's instructions for returning to normal activities and for giving your heart time to heal. Generally, healing is completed in about 12 weeks. You should address specific questions regarding your progress with your physician. Thank you for watching. This video was created by St. Jude Medical to provide information about sudden cardiac arrest. This is not a substitute for medical advice. If you have questions about a heart condition, please talk to your physician.
Hi, I'm Dr. Richard Luceri. The following informational video provided by St. Jude Medical will offer you more information on sick sinus syndrome. It will lead you through a description of the disorder, symptoms, risk factors, and treatment. Sick sinus syndrome, or SSS, is the name for several heart rhythm disorders in which the sinoatrial or sinus node does not work the right way. According to the American Academy of Family Physicians, this progressive disorder affects 1 in 600 people known to have heart problems. Sick sinus syndrome is a type of bradycardia or slow heartbeat in which the sinoatrial node, the heart's natural pacemaker, is not functioning properly. This means that the electrical signal that prompts the heart to beat either moves too slowly through the SA node, called sinoatrial block, or that there are pauses in delivery of the electrical signal to the heart, called sinus arrest. SSS can also cause tachycardia, heart rates that are too fast, or bradycardia-tachycardia syndrome, heart rates that fluctuate between being too slow and too fast. Sick sinus syndrome is not always accompanied by symptoms. However, many patients experience fatigue, weakness, dizziness, lightheadedness, fainting, and shortness of breath. While SSS can occur without apparent cause, there are some risk factors that prompt its onset. Controllable factors include high cholesterol, high blood pressure, diabetes, smoking, alcohol abuse, stress, and certain medications. Non-controllable risk factors include family history of heart disease, congenital heart disorders, advancing age, and gender. Because sick sinus syndrome can cause either slow heart rate, bradycardia, or fast heart rate, tachycardia, there are multiple treatment options depending on the arrhythmia. Bradycardia is usually treated with a permanent pacemaker. A pacemaker is a small artificial device that is designed to regulate the beating of the heart. Inside the pacemaker are a battery, which acts as a power source for the device, and a microscopic computer that listens to the heart's native electrical rhythm. If the device doesn't sense any electrical activity within a certain time, it stimulates the heart to beat. Bradycardia-tachycardia syndrome is treated using a combination of methods: a pacemaker to control the bradycardia and medication to manage the tachycardia. This video was created by St. Jude Medical to provide information about heart failure and cardiac resynchronization therapy. This is not a substitute for medical advice. If you have any questions about a heart condition, please talk to your physician. Thank you. Hi, I'm Dr. Richard Luceri. The following informational video provided by St. Jude Medical will offer you more information on bradycardia. It will lead you through a description of the disease, therapy options, and post-surgery information. Taken from the Greek words brady, meaning slow, and cardia, meaning heart, bradycardia, literally translated, means slow heart. In medical terms, bradycardia is defined as a resting heart rate less than 60 beats per minute. Bradycardia, or bradyarrhythmia, meaning slow rhythm, occurs when the heart beats slower than normal. It is caused by conditions or medications that slow or disrupt the regular rhythmic impulses that keep the heart rate normal. These causes include coronary artery disease, electrolyte imbalances, and some other heart medications. As a result of this slow rhythm, the heart may not pump enough blood to meet the body's needs. As the heart rate declines, insufficient blood flow to the brain occurs, causing lightheadedness. Other symptoms include shortness of breath, palpitations, and chest pains. However, it is important to note that some people with bradycardia do not show any symptoms, and some people with slow resting heart rates, like trained athletes, do not have bradycardia that requires treatment. Symptomatic bradycardia is usually treated with a permanent pacemaker. A pacemaker is a small artificial device that is designed to regulate the beating of the heart. Inside the pacemaker is a battery, which acts as a power source for the device, and a microscopic computer that listens to the heart's native electrical rhythm. During the implantation procedure, a lead or pacing wire is inserted through a vein in the body. The tip of the lead, called an electrode, is then placed into one or more of the heart's chambers. The other end of the lead is attached to the pacemaker, which is usually placed just under the skin below the collarbone. If the device does not sense any electrical activity within a certain time frame, it automatically stimulates the heart to beat. After having surgery to implant a pacemaker, you may experience some initial discomfort. However, soon after the procedure, you will notice that the symptoms of bradycardia are lessening and quality of life is improving. Perhaps the most important factor in the recovery process is getting regular checkups. During each visit, your doctor will use a computer to collect information from your device, interpret that information, and sometimes change the settings to adapt to your condition. Your doctor will also check the battery of your pacemaker. The pacemaker battery lasts, on average, between 4 and 6 years. When the battery begins to run low, your doctor will schedule a simple surgery to replace the pacemaker. Most patients leave the hospital the same day they check in for the procedure. This video was created by St. Jude Medical to provide information about heart failure and cardiac resynchronization therapy. This is not a substitute for medical advice. If you have any questions about a heart condition, please talk to your physician. Thank you.
Hello, I'm Dr. Marie Noel Langen. The following informational video, provided by St. Jude Medical, will discuss the use of automated external defibrillators, called AEDs. According to the American Heart Association, almost 900 people per day are victims of sudden cardiac arrest. That is 325,000 people a year struck with sudden cardiac arrest, referred to as SCA. Sudden cardiac arrest is caused by an electrical short circuit in the heart that makes the heart beat erratically and too fast. It often occurs without any warning and no prior indication of heart disease. People that have survived a previous heart attack or have certain types of heart disease may be at greater risk. In treating a person experiencing SCA, there are 4 important steps to help increase chances for survival. Call 911 to notify emergency personnel. Give CPR. Use an automated external defibrillator, AED, and transfer the person to the advanced care of paramedics and hospital staff. Studies have shown that in cases when a person receives prompt CPR, combined with the use of an AED, they stand a much better chance at survival. If defibrillation is received within the first few minutes of a sudden cardiac arrest, up to 74% of victims can be saved as the AED returns the heart to normal rhythm. For every minute that a person in cardiac arrest goes without being defibrillated, the chance of survival decreases by 10%. If a person is not treated within 4 to 6 minutes from the onset of SCA, the results are most likely fatal. On average, it takes EMS teams in the U.S. 6 to 12 minutes to arrive. Therefore, to give you the immediate attention necessary for a person to survive an SCA, it is often a bystander, not the paramedics, that must administer CPR and use an AED. You are probably familiar with the term CPR. It stands for cardiopulmonary resuscitation. This is when you aid the person by performing chest compressions and mouth-to-mouth resuscitation. CPR keeps blood with oxygen flowing to the heart and brain. CPR also keeps the blood circulating to the major organs, but it cannot restore the heart to a normal rhythm. Automated external defibrillators are used in combination with CPR. An AED is a computerized device that delivers an electrical shock to return the heart to a normal rhythm. These devices are often located in public spaces such as airports, government buildings, and sports stadiums. Public access to defibrillation programs can raise survival rates for out-of-hospital cardiac arrest from below 5% to as high as 50%. Estimates show that widespread availability and use of automated external defibrillators, AEDs, could save as many as 50,000 Americans each year. AEDs are made to be used by anyone. They come with visual and audible directions to guide the user through each step. The user attaches the AED to the victim with the adhesive pads included with the device. They will then turn on the AED and follow all of the directions exactly. The computer will analyze the heart rhythm and determine if a shock is necessary. While instructions are provided with the devices, there are several programs offered to give you more detailed training in CPR and the use of AEDs. These programs are offered in your community by the American Heart Association, the American Red Cross, and the National Safety Council. Educate yourself on CPR and the use of AEDs so you can help save someone from the often fatal effects of sudden cardiac arrest. If someone survives a sudden cardiac arrest with the help from an AED, they should talk to their doctor to see if they are a candidate for an implantable cardioverter defibrillator called an ICD. The ICD is a device that is placed under the skin and monitors the heart's rhythm. If the rhythm becomes irregular, the ICD delivers a shock to the heart to return it to normal rhythm. Thank you for watching. This video was created by St. Jude Medical to provide information about the use of AEDs. The video is not a substitute for detailed training in CPR or the use of AEDs.
Hi, I'm Dr. Aisha Arshad. The following informational video provided by St. Jude Medical will lead you through a description of ventricular fibrillation, therapy including techniques, and post-surgery information. According to the National Institute for Health, ventricular fibrillation is a serious condition responsible for 75 to 85% of sudden cardiac death in people with heart problems. Ventricular fibrillation is a very fast, chaotic heart rate that occurs in the lower chambers of the heart and results from the ventricle's attempt to control the heart's rhythm. Ventricular fibrillation can occur spontaneously or when ventricular tachycardia, a chronic cardiac arrhythmia or abnormal heart rate, has persisted too long. When the ventricles fibrillate, they do not contract normally, so they cannot effectively pump blood to the rest of the body. Ventricular fibrillation can quickly become more erratic and result in sudden cardiac death, which is also referred to as a cardiac arrest. The first and usually only symptom associated with ventricular fibrillation is a sudden loss of consciousness due to inadequate blood supply to the brain. Often ventricular fibrillation can occur spontaneously without any known risk factors associated with its onset. In other cases, it may be the result of uncontrollable factors like a family history of heart disease. Ventricular fibrillation is often seen after a patient has a heart attack, when there are extremely low levels of potassium in the blood, and it may develop in the presence of Wolff-Parkinson-White syndrome or during atrial fibrillation. Other non-controllable risk factors that precede the onset of VF include congenital heart disease, advancing age, and gender. Controllable risk factors include high cholesterol, high blood pressure, diabetes, smoking, alcohol abuse, stress, and certain medications. Chances of surviving ventricular fibrillation once it evolves into sudden cardiac death are small unless it is corrected immediately via a shock from an external defibrillator. In external defibrillation, 2 paddles are placed on the chest, which deliver a high-energy shock to the heart, jolting the heart out of VF and back into normal rhythm. If the patient survives, an implantable cardiac defibrillator, or ICD, may be implanted to help prevent sudden cardiac death. An ICD looks and works much like a pacemaker. It is implanted under the skin of the chest and attached to 1 or more leads or pacing wires, which are placed in or on the heart muscle. This enables the ICD to detect VF and deliver a small electrical impulse to the heart to restore the heart's normal rhythm when necessary. Thank you for watching. This video was created by St. Jude Medical to provide information about ventricular fibrillation. This is not a substitute for medical advice. If you have questions